practices and programs and policies that do not reflect Indigenous needs, priorities, and self-conceptions, all of which stem from a history of colonialism, including removal from land and forced loss of language, elimination of culture, forced assimilation, and genocide against Indigenous people. In order to do our work at UIHI, we have to look at the history of data and how it was weaponized as a tool to subjugate, assimilate, discriminate, and eliminate Indigenous people. A fundamental step to conducting small population research is the understanding and acknowledgement that this small population isn't by chance. There is a long history of public health and public policy in the United States that has systematically and continually undermined and destroyed the health and well-being of Native communities. I would like to share some examples of how the United States government attempted to mistreat, abuse, and harm Indigenous people in an attempt to eliminate an entire race. In 1763, British General Geoffrey Amherst deliberately gave blankets affected with smallpox to Native Americans in order to eradicate them. He considered them to be deplorable and disgusting. As a result of this biological warfare, many Native tribes experienced a depopulation, averaging 25 to 50% loss in their population. About 100 years ago, the Gila River, which was central water source and farming irrigation used by Pima Indians, was cut off and rerouted to farmers upstream. The loss of water resulted in the community being cut off from their traditional food practices and ultimately starvation and poverty of the Pima. Pima had to rely on government rations, commodity programs, which consisted of white flour, lard, canned meats, and other sugary and processed foods, and resulted in an obesity epidemic and some of the highest rates of diabetes in the world. Throughout the 1960s and 70s, it was express policy of the US government to sterilize Native American women, oftentimes without informed consent or through coercion that threatened the denial of welfare and social service benefits if the woman would not acquiesce. It is estimated by the mid-1970s, more than a quarter of all Native American women between the ages of 18 to 44, reproductive age, had been sterilized. This coordinated policy of the federal government was designed to limit the reproductive capacity of Native communities. In the early 2000s, there was a study conducted with the Havasupai tribe that collected DNA to study type 2 diabetes, but the samples were then used for schizophrenia research, tribal ancestry research, and geographical mapping, which were not included in the consent process or stated research goals, and also reflected negatively on the tribal community. This is just one present-day example of the maltreatment and disrespect of Native sovereignty. It is important to acknowledge that tribal cultures have distinct conceptions of bodily autonomy, consent, research, privacy, etc., that Western science researchers fail to understand and thus cause harm and disrespect. I don't tell you about these events to make you feel uncomfortable. I tell you about these historical traumatic events because they are the truth. And as my good friend, Dr. Don Warren states, we must walk through the truth in order to achieve equity. So what does this look like in an organization, and how do we do this work at UIHI? This is our visual mission statement: decolonizing data for Indigenous people by Indigenous people. This is ledger art, and it was created by Blackfeet artist John Isaiah Papillon. Ledger art is a demonstration of both the historical colonial registry and the way in which Native people took that practice and documented not just the diseases and the deaths, but also documented resiliency and our beautiful events, the births, weddings, ceremonies. The drawing depicts a woman dressed in regalia, proud and tall, grounded and surrounded by traditional values with corn and flowers, but also equipped to conduct rigorous, technologically advanced research and Indigenous epidemiology. Our people have always been scientists, have always been disciplined in research. We recognize that research and evaluation have always been Indigenous practices. At UIHI, we seek to use the best of Western science and technology while staying grounded in Indigenous values. So who is the Urban Indian Health Institute? UIHI is one of 12 tribal epidemiology centers funded by the Indian Health Service and a division of Seattle Indian Health Board. While the other 11 techs work with tribes regionally, UIHI focuses on serving the nationwide urban Indian population. UIHI has been in existence since 2000. All techs partner with local tribes and communities to improve health and well-being through culturally competent approaches to disease control and prevention. Techs often coordinate between tribes, the Indian Health Service, other federal agencies, state governments, and academic institutions. As a tech, UIHI has 7 core functions. We collect data, we evaluate data and programs, we identify health priorities for urban communities, we make recommendations for health service needs, make recommendations for improving healthcare delivery systems, we provide epidemiological technical assistance to urban communities, and we provide disease surveillance for urban communities. In addition, UIHI serves to improve the health and well-being of American Indian Alaska Natives by understanding and identifying health disparities and resiliency, by strengthening public health capacity for American Indian and Alaska Natives, and by advocating for health promotion and disease prevention programs grounded in Indigenous methodologies. So here is a map of the 12 techs, tribal epidemiology centers, and I want to note that the tribal epidemiology centers are designated public health authorities. Of the 12 tribal epidemiology centers, UIHI is the only one with a focus on urban communities and has a national scope. And here is a map of the Urban Indian Health Network. The Urban Indian Health Network is made up of more than 60 health, social service, and faith-based organizations that provide services to urban Indigenous communities. These organizations are private, not-for-profit, that vary in size, vary in the types of programs offered. A third of the clinics we work with are federally qualified health centers. Cities that aren't present on the map don't indicate that there isn't an urban Indigenous community there, but rather a lack of investment in organizations that serve urban Indians. In addition to this, Urban Indian Health Network, UIHI is committed to providing technical assistance and resources to community partners, academics, and state and local health jurisdictions. So now I want to spend some time about discussing what decolonizing data means. When we talk about decolonizing data, we are talking about reclaiming the Indigenous values of data collection, data analysis, and research, both qualitative and quantitative research. We're talking about data for Native people by Native people and recognizing the inherent strength of Indigenous people. Decolonizing data encompasses Indigenous methodologies, Indigenous epidemiology, Indigenous research, and cultural rigor. At UIHI, we're initiating the shift into decolonizing data by introducing culturally rigorous science, reclaiming Indigenous values, and using our knowledge to bring health back into Indian population and community. Indigenous methodology means that we look to incorporate our methods and work the strength of kindness, compassion, gratitude, love, and the act of gifting and receiving. From our culture, we have identified and recognized that these characteristics are of bravery, courage, determination, endurance, patience, perseverance, and well-being. We do this work with prayerful intent for future generations. Indigenous epidemiology is applying additional knowledge for strength-based analysis of Indigenous data. We analyze data with prayerful intent for the well-being of our people. Indigenous research is a radical act of resistance against all that has oppressed us. Our research, Indigenous research, is done for the love of our people and recognizes that we have always been scientists and researchers. Lastly, cultural rigor means being grounded in cultural knowledge and supplementing when needed with Western science, making sure that we tell and include our stories in the work that we do. So as we decolonize data by using Indigenous methodologies, Indigenous epidemiology, Indigenous research, and cultural rigor, we are able to decolonize research. We at UIHI see that science and Western academics have oppressed Native American communities for many years. Decolonizing research is a process for conducting research with Indigenous communities that places Indigenous voices and knowledge at the center of the research process. It critically examines underlying assumptions that inform the research and challenge the widely accepted beliefs that Western methods and ways of knowing are the only objective true science. We are told repeatedly that Western science beliefs and methods are the true science, beliefs, and methods. This type of thinking marginalizes Indigenous methods and ways of knowledge. It denigrates our voices, knowledge, and experience as folklore or myth. At UIHI, our research centers around Indigenous values and follows Indigenous protocols. So who are American Indian Alaska Natives? American Indian Alaska Natives are a diverse community living in different locations ranging from tribal lands to metropolitan urban areas. Based on the 2010 US Census, there are 5.2 million American Indian Alaska Natives, alone or in combination, living in the United States. Of that, 78% of American Indian Alaska Natives live off of reservations. 71% of those individuals, Native Americans, Alaska Natives, live in urban areas, and approximately 1/4 live on reservations. So now that we have an understanding of the distribution of American Indian Alaska Natives and where they reside, I want to discuss the challenges of conducting epidemiological research in American Indian Alaska Native communities. In a research, policy, and societal context where epidemiological evidence and data are critically important, we work to provide accurate, actionable data, but have some unique considerations and challenges. These challenges overlap and interrelate and have very real impacts on our understanding of urban Native communities and their health risks, behaviors, strength, and patterns of resource allocation. The first of these data challenges is a lack of data. And what do I mean by this? American Indian Alaska Native are a small population. As I stated before, there are approximately 5.2 million American Indian Alaska Natives in the US, according to the 2010 census. The population isn't that large to begin with, and the more granular you get in terms of stratification for health outcomes, demographics, and geography, the fewer people you have to work with to record meaningful data. In addition, there are limited data resources available. Particular to the work of UIHI is a lack of data sources that collect race or ethnicity data and geographic data. This greatly confounds our ability to conduct research specific to the health of urban Indians. Also, state and national health departments don't provide data that is more granular than state level, which obscures variability in population health linked to geographic context. Next, let's talk about the challenges regarding Westernized systems. For instance, the biomedical epidemiological method. This model guides our federally funded research paradigm in the US and requires researchers to justify the need for a study using evidence-based practices. And also Westernized paradigms that are often insufficient in understanding the health and well-being of Indigenous communities. So when we talk about evidence-based practices, the question that comes to mind is, whose evidence are we talking about? Is it Indigenous evidence-based practices? Another challenge we seek is a lack of cultural relevance with data collection tools. Most data collection tools are not culturally adapted and do not ask questions that hold resonance for Native communities. Thus, the results cannot fully inform policy and programs in Native communities. Now let's talk about invisibility and erasure. Collapsing racial data into other or into multiracial categories frequently makes American Indian Alaska Natives invisible. Too often in the publication and presentation of data, racial groups with small numbers are collapsed into a catch-all other category that renders each group to be invisible. Additionally, with growth and recognition of multiracial individuals, data collection is increasingly allowing for individuals to identify with more than one race. However, those individuals are homogenized when their race is reported simply as multiracial. Without further breakdown and enumeration of the different racial combinations, we resort to assessing racial strata as one, thus allowing for a population to be erased and omitted from reports. This tells Indigenous people they are not important, they are insignificant, or they don't matter. Also, we must take into account the suppression of small numbers. It is standard epidemiological practice to suppress small numbers out of concern for protective health information, and because small samples often yield statistically insignificant results. When applied without question or consideration of alternate strategies, is yet another form of erasure leading to invisibility of Indigenous people. Lastly, when talking about data challenges regarding urban American Indians, Alaska Natives, we must address the variability in data governance and presentation and the concerns with missing data. Regarding the variability in the collection, analysis, and presentation of data, we see a wide range of methodologies that create inconsistency in available data. For instance, how is American Indian Alaska Native defined? As alone or in combination with other races? How is race identified? As self-identification as enumerated in the US Census, or tribal enrollment, which the Indian Health Service and other federal agencies use? There needs to be a greater transparency and documentation about methodologies and a greater exploration of the implication of these choices. Also, we must address high rates of missing data in both race and ethnicity and health-related fields of data. Often we accept the high rates of missing data and exclude from analysis, instead of questioning and challenging the methods and processes of collecting data. So now I'd like to concentrate on racial misclassification as it is a prevalent framework in the underestimation of the actual American Indian and Alaska Native population. Racial misclassification is the practice of assigning other races to American Indian Alaska Native people such that they are not recorded as Indigenous. There are many mechanisms by which racial misclassification comes about. So what are these causes and factors that result in racial misclassification? First, tribes that were formally recognized is a reason for misclassification. Federal and state policies have certain points rescinded recognition of tribes. This does not change those members' identity as Indigenous people, but does alter their access to resources. Second, the use of Spanish surnames to determine race. Particularly in California and the Southwest, we see ethnicity enumerated solely on the basis of Spanish last name. Third, self-identification with multiple races. In the 2010 census, just under 45% of American Indian and Alaska Natives self-identified in combination with another race or ethnicity. While the census is designed to enumerate and capture this reality, many data collection tools only have the dimensions to capture a single race identity. Fourth, changes in tribal enrollment. Each tribal has authority to establish tribal enrollment policies and standards, and to also change them, which can shrink or expand formal tribal roles and cause confusion. Fifth, American Indian Alaska Native is not a category. Some data collection tools and input tools don't have American Indian Alaska Natives as a response category. Six, inconsistent definitions of American Indian Alaska Native. Different data sources have different definitions. Seventh, imprecise definitions of American Indian Alaska Native. Some sources use self-identifications while others use tribal enrollment. Next, changing self-identification. Racial and ethnic identity is an intensely personal thing and people have the right to evolve in their self-identification. Ninth, a tribe is not federally recognized. At present, 573 tribes are federally recognized. More are recognized at state level, and an untold number have been excluded from formal recognition. Next, fear of racism. American Indians and Alaska Natives may not report that they are Native for fear of being discriminated. Also, we have recorded at UIHI instances, particularly with our Missing and Murdered Indigenous report, in which police departments and coroners' offices code American Indian and Alaska Native as white. We see this as there isn't any value in coding them as American Indian and Alaska Native. There is an assumption that white is the default or norm. Lastly, subjective observation of the data collector. Particularly for mortality, there are instances of racial misclassification that arise from the subjective observation of a coroner or medical examiner. So how can we correct and address racial misclassification? One strategy is to conduct specific research on American Indian Alaska Native populations and communities. We should work with Native communities to understand how they want to be enumerated and identified, and also to identify topics that are relevant to our communities. Another avenue would be to support linkage projects like the Improving Data and Enhancing Access project, which UIHI collaborates on with the Northwest Portland Area Indian Health Board. This type of project compares public health data with tribal enrollment lists to identify cases of racial misclassification and then correct those counts for the state of Washington. Lastly, report limitations of work. It is important to list and discuss limitations in any research project so those considerations can be accounted for in evaluating the results and outcomes. We must, for future endeavors, seek to address and improve upon these limitations. In the next few slides, we'll share some of the results from the Northwest Linkage Project. So this is a slide that shows data from CHARS 2010 and 2011, and then mortality data from 2010, and data from trauma from 2005 to 2009. And I wanted to have people look to the far right, or the last row, showing the percentage of racial misclassification. So we identified there was a total of 700, for the first line, there was in the CHARS of 2010, there was 700,046 that were identified for the linkage case. And what we found was that there was a 32% misclassification of those records. You see on the CHARS, there was a 27% misclassification prevalence for that. And then there was approximately 8% misclassification for the death records in 2010. And then for the trauma records, we see that there was approximately 42% rate of misclassification. So here, during the 2010 and 2013, this is another project. This is looking at CHARS data. What we find, if you look at the pre-link of 6,919, that was the age-adjusted discharge rate for American Indian Alaska Natives. After the linkage projects where we corrected this, post-linkage was 9,102. That was the adjusted rate for hospital discharges. We see that it's 32% higher than the pre-linkage. Here's another example of a linkage project and looking at CHARS data from 2014. And so you see the pre-linkage is 6,675 and the post-linkage is 9,307. This is 39% higher rate after the records were collected. And I want to note the previous slide and this slide, the differences are significant. Look at the outcomes on these. And on this one, we're looking at mortality rates for state of Washington 2014, and you see the pre-linkage of 1,046, compared to the post-linkage of 1148. We see that the post-linkage is about 10% higher. Lastly, the Northwest Project also looked at mortality statistics for the state of Washington and conducted linkages within Washington state tribal roles. Well, the numbers, just looking at the last column, while the numbers of the additional cases may seem small, it's important to think about the relatively small overall population. It's important to think about the relatively small overall population which these cases are coming from. When the top 10 mortalities are aggregated together, it's almost a tenth of the total deaths in the study period. So there are important efforts that can be made for correcting racial misclassification. Correcting for racial misclassification is important to our practice of Indigenous epidemiology. In addition, there are many other strategies to conduct small number analysis. So what are the other strategies that can be used to increase sample size and allow us to conduct small number analysis? Well, aggregating across data time, building a longer time frame for your analysis. 3 to 5 years is a simple way to build a larger sample size. Use weighted sampling. This gives increased strength to small populations. Oversampling American Indian Alaska Native population. Specifically, design data collection practices to capture individuals that identify as American Indian Alaska Natives. Next, we should limit our stratification. More stratification often reduces sample sizes to very small numbers. Next, as I stated before, use data output from linkage projects. As shown by the Northwest projects, conducting linkages can be an important and powerful way to increase the sample size in our study population. Hence, we must support these types of efforts. We also must report our limitations in our work. If you are unable to increase the sample size, explain why increasing the sample size was not feasible. It's important to list limitations in any research project so those considerations can be accounted for when considering the results and outcome from the analysis. Also, reporting limitations will allow future endeavors to address and improve upon these limitations. In our effort to promote the health and well-being of American Indian and Alaska Native communities, we must question and address methods that limit the quantity and quality of data. For instance, it is important to advocate for how data is collected. This includes allowing individuals to identify multiple races on data collection tools. We must include multiple race fields in data sets, and we must avoid reporting multiracial and other categories when possible. For example, when UIHI builds and designs primary data collection tools, we follow these practices. We also work in consultations with state and local health jurisdictions on expanding definitions of American Indian and Alaska Natives. Next, collect culturally relevant information. Ask questions and design projects that are relevant to Native communities and are culturally specific. We should consult Indigenous organizations and people. For example, UIHI is designing and conducting an urban Indian burfest that will include questions on historical trauma and resiliency. In addition, we should conduct mixed methods research. Storytelling is important in Indigenous communities. We should conduct focus groups and any key informant interviews. For example, when UIHI conducted a needs assessment for urban disabled and elder Natives in King County, we coupled quantitative data with data from focus groups for our report. Also, it is important to understand that when something is not statistically significant, it does not mean a problem does not exist. Often epidemiologists have findings that are not statistically significant, but that doesn't mean that data isn't important or not indicative of change or disparity. Lastly, report strength-based results. Much of public health funding and attention focuses on disparity and deficit. UIHI in our reports provide an alternative that recognizes the strength and resiliency of our urban Native communities. The most significant impact of insensitive research is the perpetuation of the myth that Indigenous people represent a problem to be solved and that they are passive objects that require assistance from external experts. Too often, health research documents document significant issues and problems using inappropriate methods of identifying those problems, with a resulting overstatement of the negative aspects of those communities. It is no surprise that individuals and communities feel stigmatized when this research is published. No community wants to have the reputation of having the most alcoholics or the most people with mental disorders or the most suicides. So I would like to conclude by saying it is important that American Indians and Alaska Natives reclaim narratives of their Indigenous health and well-being. Today, we have mostly focused on the epidemiological side of UIHI in conducting research and working with urban Native communities. But the work that UIHI does is vast in terms of the elements for Indigenous methods and practices. We use these elements to assess and evaluate urban American Indian Alaska Native population. We also use these elements to provide accurate and meaningful data that is relevant and reflects the unique cultures, traditions, and health needs of urban Indian communities. Everything we do is for the love of our people. It is done in a spirit of generosity and gratitude, rigor and respect. We engage and collaborate with our people and community. We put them first and allow them to guide us in our endeavors. Our work is anchored and grounded in traditional values. It empowers our community to walk in a culture of wellness. This is who we are. Don't come to us because you think we have the problems. Come to us because we have the answers. So at this point, I will actually now entertain some questions from participants. So there is a question here from Angela. Does health include both physical and mental health, or one or the other? For us, health includes both the physical, mental, spiritual well-being of an individual. When we look at the person as a whole and don't necessarily exclude one or the other. I'm going through some questions here. Can you talk more about the burfest being done among urban American Indian? Are there questions being added that address specific cultural issues? So this past year, what UIHI has been doing is developing a urban burfest. Many of the questions are similar to the burfest that is conducted by the states, by CDC. However, we have also added questions looking at resiliency, looking at historical trauma, and assessing those components and the impact that it has on the health and well-being of the individual. We're also looking at the level of connectedness to community and to family. These are questions that are not, have not been part of the burfest that is conducted by the states. These are specific questions that we have identified and are testing right now that are specific to the indigenous population. There's a question of, will you share a copy of the PowerPoint after the webinar? We certainly will will be sharing the presentation. And there's another question here. How do you define American Indian, Alaska Native when they are multiple race for the denominator when calculating rates? So at UIHI, what we do is we preferably use in our for our denominator the American Indian, Alaska Native only plus American Indian, Alaska Native in combination. That's the preferred denominator that we like to use. However, that's not always the case. Some data sources do not allow us to disaggregate the information or the data, and so we end up just using American Indian, Alaska Native only in our denominator. That's not our preferred way, but you know, that's sometimes all we can do. Another question is, are you utilizing ACEs in any of your measurements? We are looking at ACEs in the, we have questions on ACEs in the BRFIS that we're developing for urban areas. So there's a question here, how do you avoid further stigmatization of American Indian, Alaska Native populations when reporting health disparities? I think it's important, and we need to, one, acknowledge those disparities, but one of the things I talk to my staff about, and that we try to do here at UIHI, is also to show the strength in these outcomes. I think many times that we're taught in you know, our schooling is to just focus on the negatives, on the deficits, like who has the highest rate of diabetes or who has the highest rate of smoking, right? And instead, what we try to do is, like, among those that don't smoke, why are they not smoking in American Indian, Alaska Native communities? And focus in on that and really look and share and report out those strength-based outcomes. There is a lot of good in the data that we have. There's a lot of good information that shows the power and resiliency of American Indian, Alaska Native communities. I don't think that gets reported out on a lot of reports, and I think that we need to change that mindset and that shift to report those strength-based outcomes as well. So that's what I would try to do. That's what I would say, you know, to do to avoid further stigma. Another question here is, do you ever work with social scientists? For example, I'm a sociologist, and culture is a significant component of what we examine. We haven't worked with social scientists specifically. It's not that we're not, we certainly would look into potentially doing that, and it just depends on the project that's at hand. We have staff here, a lot of staff have skill set in sociology. Some staff that have degrees in that. So, you know, we look to them for guidance as well. But like I said, if there's individuals that would like to work with us, I mean, we're open to that. It just depends on the project. So we have another question here is, what is the appropriate level of stratification or granularity of American Indian, Alaska Native population subgroups for data collection and reporting? I think it depends on the data itself, on the data that we have. Some, depending on what your N value is, some data may have quite a large N value, where some has limited N value or a small N value. And depending on that, that would guide whether we would do additional stratification. In some instances, all we can report out on would just be on American Indian, Alaska Native on the whole, general population. If there's enough data, I have staff that will stratify by gender. We might stratify by age group. We might stratify by insurance status, by poverty level. It really depends on the data source and the amount of data that's available to us. So another question is, if an organization is assisting a task force to address a specific area of concern, such as murder and missing Indigenous women, what would be the best and most appropriate way to begin that respects women, their experiences, and their sovereignty? I would actually, this is something that if you would want to reach out to UIHI, and we would have, we could certainly give you some guidance on that. I think one of the things that needs to be done is to, if you're going to be capturing these stories need to be heard and talked about. But I think that there are steps in how that data should be collected, and certainly there are approaches on how to go about having people participate in this. I would suggest that you reach out to us and we can go more in depth about that. We have a specific group here. Our director, Abigail Echohawk, is leading those efforts, and she'd be more than happy to discuss that with you. So there's a question here from Gail. For a linkage project, does it take an Indigenous organization to conduct? Do tribes trust other entities with enrollment data? Right now, I don't. You would have to go through, you'd probably have to, I would suggest that you try to go through one of the tribal epidemiology centers. Northwest has a system already set up. I think it would be very difficult for other organizations, such as like universities, to do this type because of trust issues, and you would have to go through an IRB as well. It's not something that is just easily done. There are a lot of there's a lot of stuff that has to be done before we could do this, and so it's not. I would suggest, like, talking to Northwest Portland Board and seeing what they do. For the linkage project, what data sources did you link together? So it's the tribal enrollment that they have, for the state of Washington. So it's tribal enrollment for the state of Washington, and we looked at CHARS data for the state of Washington, looked at mortality data for the state of Washington, and there was another one. I believe it was trauma data that was also looked at. What was the definition of American Indian Alaska Native used in the Washington study? Can you provide a copy? If you are talking, I'm not sure which study you're talking about. Angela, if you could explain which paper we're talking about. So looking at more questions here. What is UIHI's work to change policies with state and federal programs, even to grants? We have a policy person here, Aaron Sparks, who is part of Seattle Indian Health Board. We work with him very closely, and he goes out and works with legislators. We provide him the information that is needed to address some of policy changes. I have worked with other organizations, state health departments, in addressing how we define American Indian Alaskan Natives and how that needs to be changed. Abigail Echohawk also works with legislators in addressing the methods on how data is collected and how data is being analyzed. I have worked with different legislators as well, and community members in trying to address how data is being presented, how data is being captured. The tribal epidemiology centers work together to also change policies and how grants are presented and requirements for those grants. So here's a question on how is historical intergenerational trauma taken into consideration when conducting data collection? A community fatigued with being treated and not healed will be reluctant to participate in research. So that's a really good question. We're in the process of developing that. Like I said, like part of the work that we're doing with regards to like the Burfus, urban Burfus that we're developing, is creating questions on that, and we'll be testing to see, you know, the effects that it has. I think that this has not been done before at the level that we're looking to do it on, and I think that this is something that's really important. We have done some initial tests on it where we've collected data. People are apt to answering those questions, and they are willing to share information regarding their experience and the impact that it has on their health and well-being. But like I said, we're at the very beginning stages of this, and we're testing this information out. So question here on how do you feel about comparison data, and if you were to, who do you typically compare to? Non-Hispanic whites or all races? So typically what we do, our standard process here at UIHI is to compare to non-Hispanic whites, which is the dominant population. That's historically who we've compared to. And we take Hispanics out of that because Hispanics also have a different level of risk than white Caucasians. So that's who we typically compare our data to, is non-Hispanic whites. So what sort of healing is built into data collection? For example, maybe including presenting how data was collected before and why errors in reporting Indigenous arose. I think for us, I'm going to try to answer this question. I think for us is one, when I go out and I work with organizations and work with communities, is to, one, speak about how data has been used in the past to hurt certain populations, and understand how those processes have really tried to eliminate certain populations. I think part of the healing process is to acknowledge those, what has been done in the past and make sure that that doesn't happen again. I think it's important to be advocates and to be the voice of those that have been marginalized, that have been mistreated, and in making sure that how data is collected is collected in a respectful way, and how it's presented is also in a respectful way. We certainly try, when we are doing our analysis and data collection, we seek input from our communities and have them guide us on how we should do our work. Are you able to share your methods and lessons learned from the linkage projects with other techs so they can do similar work with tribes that they serve? We certainly can, share the work that we have. I would also reach out to Northwest Portland Indian Health Board. They're actually the ones that are doing it. We are collaborating with them, but they are actually the lead on the project. So, I think, is there any other questions? We're just looking at questions here. So when working with urban Indians, how should researchers make sure that tribal government retains data sovereignty when participants are not living under tribal government boundaries? I think that's sort of a tricky thing for us to do. The other tribal epidemiology centers work directly with the tribes who are sovereign nations. For us in the urban Indian populations, we see them as tribal people living off their tribal land in urban areas. We try to collect information on their tribes. That's not always possible. And we also actually try to work closely in our work, with tribal organizations that are surround urban areas or are in urban areas, and making sure that they are part of this process, and data that's being collected, make sure that it's being collected in a respectful way. And I think I would just say to have that communication, that any data that's being collected on American Indian Alaska Natives, whether it's from tribes or whether it's in urban areas, that we do it in a way that does not hurt the population, is being respectful, and that we allow them to be part of the process, the entire process of, from collecting the data to also how data is going to be analyzed, and then how data is going to be presented. And then there's the last question we have here is, do you include Hispanics? If we are able to, we don't include Hispanics in the white non-Hispanic or the white population. We do if we're able to identify Hispanics for American Indian Alaska Natives who identify as being Hispanics, but also American Indian Alaska Native. We will include them in our analysis. So that we're running out of time, and I believe Gunnar wants to do an evaluation. I want to thank everybody for your participation in this. I really appreciate you guys taking the time to be with us today. I hope there's some information that you were able, the information that was presented to you was valuable. We will certainly put this presentation up so you have access to the slides. Let me put my here is my contact information. If anyone wants to contact me directly and we can discuss this further, or I can share some of the resources that we have.
All right, everyone, one last thing. I'm gonna pull up some evaluation questions. These are just some simple questions which help us improve our content going forward. So please take a quick second to go through these questions and answer them. We don't have any space here for any open form feedback, but if you do have anything you would like to share, any suggestions, any recommendations or anything like that, please reach out to us. You can reply to the email that you received when you registered for this webinar. Thank you. All right, I think we're good.